Hello everyone and welcome to the 7th webinar we're doing on the CamAPS system. Please keep your cameras off and your mics on mute for the duration. The panel will have their cameras on, so you will be able to see them and get some information. We'll be starting very shortly, but just before we start, just to make you aware, we're having 2 more webinars, one for next month on young adults and then going on to April about meals, exercise and other sort of life events, and then we will plan further ones, so don't think this is the end, so please join us for that. The panel today is a lovely big panel with lots of expertise. So we've got Julia and Sarah from Addenbrooke's, we've got Fiona Campbell from Leeds, we've got the Giles family who are going to share their experience, and I'm just in the background facilitating. So thank you to the panel for giving up their time. I'm really, really pleased, and I can't wait to hear all those pearls of wisdom from you. But without further ado, we're going to get on, and I'm going to hand over to Sarah. So Sarah, please take us on.
Great, thank you. So the outline of what we're hoping to kind of cover this evening is just a really quick overview of the system and how it works, just the inputs that make a difference. I think a lot of people will have either been using the system or seen other webinars that go through it in more detail, and they are available if you want to kind of go back and get more information around that. We're just going to whiz through that. Then just an overview of diabetes in very young children, thinking about what all those burdens are and how the system can help make those hopefully easier. Really lucky to have the Giles family with us, so they can talk us through kind of their experience of using the system. And we're going to talk about kind of glucose targets, just starting points, the things that you might want to set up, the way you might want to set the system up in young children, and then the things that tend to crop up and cause trouble: managing meals, managing exercise, managing hypos, and that kind of evening rise phenomenon that seems to be a real problem for a lot of people with young children. Thanks. Next slide, Candice. Thank you. And so just a quick overview of how the system works, just as a reminder. So the system modulates insulin delivery by turning off the pump's basal, normal basal setting, which then just becomes the safety default if the system loses connection from CGM and can no longer deliver in auto mode. And you'll see when it's in auto mode, it flashes no delivery, just as a reminder that that means no basal delivery, it is delivering insulin. And then it works by, instead of having that normal basal pattern, it adjusts by running a new extended bolus every 8 to 12 minutes. If there was an issue with a delivery problem because it flashes no delivery, sometimes people are anxious about that. Just to reassure you that it would be alarming or vibrating and beeping, buzzing, saying no delivery occlusion, no delivery low reservoir, no delivery low battery, that kind of thing. So just a reminder as well, it's hybrid closed loop, which means it still requires insulin boluses for carbohydrates. Next slide, thank you. And so just a reminder of the inputs that make a difference to the system. So the system takes the CGM data and it learns as it goes along in terms of the person's insulin sensitivity and predicting future glucose levels. So it optimizes and it predicts and adapts as time goes by. The only inputs we use to start the system is body weight and total daily dose, and the algorithm calculates the rest. So even though you'll have all your normal settings on a pump, it's only the carb ratios that are making a difference to the system and the personal glucose target that you can set when you're in auto mode. Obviously, if it flips out back into open loop, then all the normal pump settings would come into play again. So it's important that they're set correctly. So the adjustable settings, like I said, are the insulin to carb ratios. The glucose targets, which we're going to talk about, a good kind of place to sort of set them and why you might raise or drop them at certain times. And you can also adjust, obviously, bolus timing and make sure your set changes are at optimal times. But the system doesn't take into account the active insulin time on the pump, the insulin sensitivity, all those pre-programmed basal rates while it's in auto mode. But they are important when auto mode is not available. Next slide, thank you. So just thinking specifically about diabetes in this really young age group, and Julia and Fiona are going to run through these, but one of the main factors that the whole system has been designed for is to try and reduce the burden of care. Managing diabetes in this age group is a huge burden that many of you will be aware of. I know Fiona has some thoughts around that.
Yeah, I did. Thanks very much, Sarah. Well, while in clinic, we can be tempted just to be looking at glucose waveforms and what the insulin is doing and when we're bolusing and what the A1C is. But the most important thing from my perspective is how the family is integrating diabetes care into their everyday life. And we're talking tonight about infants, toddlers, and young children. And by definition, they are in young families with young parents who want to enjoy life as young people. And I think a really important thing for me is that this young patient is in a family that has the highest quality of life and the lowest burden of care with diabetes. And I would like to think that the use of technology was contributing to that outcome that we really need.
Yeah, I completely agree, Fiona. And I think, you know, why is it such a high burden of care in this age group? And I think, you know, we've listed some of the reasons there, and obviously a lot of you will be experiencing this every day. But some of the reasons why the burden is so high in this age group is because of the unpredictable eating patterns, frequent grazing. You can't rely on them to finish meals. So it can be very difficult in terms of bolus timing and bolus amount. Activity is really unpredictable. They don't tend to tell you if they're going to head to the gym. They have really variable insulin needs, but are also really sensitive to insulin. And all of that bound up in the fact that the insulin needs overall are quite low. So we're talking tiny doses, and sort of getting that exactly right. And you'll all have experience, you know, 0.1 of a unit can make a big difference when you're very little and you have really low insulin requirements. And then other kind of odd factors like the late evening rise that we see in a lot of children after they go to bed, not every day, but occasionally, and that I know a lot of families really struggle with. And so I think going back to what Fiona was saying about, you know, how can technology help, and why is closed loop really needed for particularly young children and toddlers? And I think the kind of diagram on the right illustrates that really nicely. So this is kind of what we look at when we look at CamAPS FX. And on the top, you can see the glucose trace. And in green is the target range that we aim for, 3.9 to 10. And at the bottom, you can see in dark blue, those kind of squiggly bits are the insulin that's being delivered by closed loop, so automatically adjusted based on the sensor glucose levels. And then the light blue is the boluses that the user gives manually, so that the parents usually in this age group would give via the app. And this is nighttime, midnight to kind of 8-9 a.m. in the same child on 2 consecutive nights. And you can see really, really nicely how the amount of insulin that's needed overnight is hugely different between the 2 nights. So on the first night, there's really a very small amount of insulin being given by the closed loop system. You know, a lot of the time there's nothing being delivered because actually glucose levels are on the lower side. And on the following night, you can see that actually glucose levels are a bit higher, and quite a bit of insulin is needed. And managing that with just normal pump basal rates is a huge burden for families. And you know, you'd get alarms all the time. You'd have to get up. You would be adjusting basals, or you'd be living with the fact that they're either low or they're high. And the beauty of kind of how closed loop can reduce some of that burden is by automatically adjusting based on what's really happening with the glucose. Yeah, next slide, please. So what are we sort of aiming for in young children in terms of time in the target range? And you'll hear that a lot in clinic, and you'll read about that a lot. And why do we even talk about time and range? So on the left-hand side, you can see, so time in the target range is 3.9 to 10 millimoles. And in the past, we used to always talk about just HbA1c, but now we kind of talk about both things, A1c and time in range. And the reason for that is that the A1c is really just an average. So it gives you the middle number over the last kind of 2 to 3 months. But sometimes the average doesn't really give you a lot of information about what's going on. So you can see that all of these 3 imaginary people have the same A1c, but they have really different time and range. So the person on the left has a lot of time where they're really high and a lot of time where they're really low. And so the middle number is sort of looks like it's where we want it to be, but actually, you know, the glucose is going up and down and up and down. And what we really are looking for more is the person B in the middle, where the majority of the time is spent in the target range 3.9 to 10, and there's not so many lows and not so many highs. And person C doesn't exist, as you will all know. And I think this ties in really well with what Fiona was saying as well, that, you know, I think impossible to achieve 100% time and range. And also the burden would be so enormous. So of course it must be balanced against quality of life and you know, still doing other things apart from managing diabetes. And on the right hand side there, you can see the kind of general consensus recommendations as to what we should be aiming for in terms of how much time should be spent in the target range, and that's 70% is what we're looking for. So we're not looking for 80% or 90%, really 70% we think has been shown to really reduce complication risks in future, we think. So actually you don't need to get 90% time in range and never sleep. And the other important thing is, of course, that when you're trying to achieve time in range of 70% or more, it mustn't be at the expense of lots of time in hypoglycemia, so lots of time with lows. So we want the lows to be 4% of the time or less, and that's really, really important. And the kind of UK target in terms of HbA1c for children is 48 millimoles. Which is lower than it used to be. It used to be a bit higher than that, and I think part of that is also that we now have things like sensors and alerts, and so we don't need to be so worried about not recognizing hypos in these young children when we sort of aim for a tighter glucose control. And yeah, like we were saying, the important thing is that it's a target. So a target doesn't mean that you have to achieve it at all costs. It means it's something to aim for, something to sort of head towards, and like we've all sort of been saying, important to recognize that that shouldn't be at the expense of a huge burden or of lots of time in hypo. Next slide, please. Great, and now we'll hand over to the Giles family.
Yes, thank you very much, Tim and Sarah, for joining us today. We just want to know a little bit more about you and, you know, your life and journey with type 1 diabetes, but also with the CamAPS system, because you've been on the system for about a year now, I understand. Is that right?
Yeah, about a year, yeah. But yeah, it's made a huge difference. Huge difference. So Leon's our little boy. We have 3 children. Our little boy with the yellow around his neck, that's Leon, and then he's got Eleanor, big sister, Naomi, middle sister, and then that's Tim and I. And we, Tim and I were completely taken by surprise when he was diagnosed with type 1. He was 2. And he was a very young 2 as well. So he had symptoms for a while, but went to see a locum GP who was like, he can't have type 1, he's too young. And that was terrible. So by the time we did actually get blood tests and stuff done, the hospital called up and said his blood sugar is crazy high, you have to come in. And he'd already gone into ketosis, and it was 2 weeks of horrible, and being taught how to use these things, and just being completely shocked that somebody this young could be diagnosed, and also all the kind of like emotions that come with it, because you don't really understand what's going to be the reality for him. And so that was really hard, kind of psychologically, but also practically, because suddenly he's having to have all these things going on, and he's still in nappies, and he was it was very difficult for like practically getting it done. And then when we got this opportunity to be part of Closed Loop and be part of the Cambridge study, I think a lot of me was like, it's going to be magic. And then a lot of me at the same time was like, thinking, well, there can't be a solution. So it was kind of like both things at once, wanting there to be like this magic solution and also feeling like nothing can fix this. Like I was very emotional about it. And I think Tim had a very different experience. And so I will pass you to Tim.
Well, I mean, I think my experience is quite similar in lots of ways. It was a huge shock, wasn't it, at the time? And yeah, that time in hospital was very hard seeing him like that. And
then we've had to be admitted since then. It's not like it was one time. It was even with all the management that we were like doing blood tests through the night, like when for the first year or so, like through the night, like getting up every few hours, like just because he was so small and his blood sugar was just so constantly.
Yeah, I mean, I think that's one of the great things about the closed loop is the nighttime thing, and that thing of just not before the closed loop of just not knowing what he was at night and what his levels were, and just being able to look at your phone and just check, just make sure he's okay.
So that's what, if you see Tim looking sideways, he's not checking his text, he's getting alerts on because Leon's a little bit slightly he's a little bit low right now. But so that's the thing, you can multitask slightly like that. So we both have apps, and other family members have got the Diascend, and so everyone can kind of keep an eye on it now. And it's been life-changing, and I'm so grateful for our family getting the opportunity. And I just everyone's been so kind, so thank you everybody. But we if I was able to recommend it to people who've got the opportunity, I would 100% recommend it, because it's not perfect, but nothing can be perfect. Like you were just saying about, there is no 100% in the green zone, but even if the levels are crazy, you've got that data in front of you. It's no longer just like kind of guesswork as to what's going on. And when you do have a young child like under 5, or even like going up to like 7 or 8, like that kind of the age of before they have kind of a little bit more kind of control over themselves, you can't imagine how much energy they're putting into doing their jumping up and down, or how their body's going to digest their dinner, like, because it's so unknown, isn't it? Like, no, you can't magically like know anything about them. You can just see what's going on. And our son, he doesn't have clear hypos or hypers. He just doesn't really show them so much. So he would be tipping into hypo on the machine now that we have, and we can catch it and we can make sure that he's okay, but we wouldn't know from his behavior because he still runs around crazy, and then he just goes whoop, and by that point it's too late. So anyway, so I don't want to like keep going on, but it is, I would 100% recommend it. It won't fix everything, but it will like absolutely change your peace of mind and add a level back into your family life that maybe you thought you could never have again. So, well, that's what I feel. Yeah,
I mean, also with him because he started school in September, and for that as well, that made a huge difference.
Yes.
Just again, just being able to see that he's okay, and having the communication with the teacher, and just being able to say, what you need to do, just by looking at the data, has been hugely helpful.
Yes.
So yeah.
Thank you very much. That sounds just amazing, and a really great insight into your life. Tim and Sarah will be around for the whole presentation, so you're welcome to ask them questions on chat, or ask them directly questions at the end of the session. So please do keep those sessions, sort of questions coming. But we're going to go on with the rest of the presentation. So I'm going to hand back to Sarah, I think. Is that correct?
Yeah, I think it is. Thank you. So just thinking about setting the system up initially for toddlers and young children. So the total daily dose is, as I said, one of the only measures that you can enter into the system, and the weight to start it off. So it's and we've had a few incidences where people have gone, a lot of people have gone straight from another pump onto the system, but a lot have gone from MDI. So it's definitely worth making sure you've calculated your kind of pump starting total daily dose when you are going from MDI onto the system, because otherwise potentially it can be a little bit too aggressive to start off with. That's all it's got to go on until it's started to learn those patterns. And then as far as the personal glucose targets, I think initially these can be really useful to just help make sure, especially initially if there's been basal insulin on board when if someone's gone straight from MDI, just to not be kind of too desperate to really kind of lower them down too quickly, or even start them on the default is 5.8. And what we find if someone's going on from injections is it can be worth just raising them up a little bit to start off with, just for the first couple of days, or at the first sign of kind of any sort of that you notice it's been a little bit too aggressive initially, just to back off a bit with the personal glucose target and then just nudge things down gently. And especially if the total daily dose is less than 10 units and they're fairly newly diagnosed as well, it's definitely worth popping that up a bit higher to start off with. And one of the big things that we've been noticing when we started is around the need to dilute insulin for these very young children. And I think all of us were kind of, I think anyone that works with this age group is kind of, you know, starting to kind of mess around with insulin dilution. Some people will have centres where their pharmacy will do it for them. Others, like ours, the pharmacy doesn't get involved. And so it can be a kind of, there's a lot of thought that needs to go into going into a sort of dilute insulin situation with a child. But certainly what you'd find is, whereas you historically tend to base things, the pump itself, the Dana pump says it can manage anything 5 units or above. What we'd noticed is if the total daily dose is getting on below 8 units, the system just doesn't cope so well. And especially if you've got situations where there is very little insulin requirement overnight compared to a bit more kind of around meals during the day, that if it's less than an 8 unit total daily dose, you definitely want to start to consider diluting the insulin. Next slide, thank you. We'll talk a bit more about the dilution thing in a minute. In terms of the personal glucose target, you can adjust it between 4.4 and 11. And what we tend to do is, if you've had someone on a pump and reasonable control, then a default of 5.8 as a starting point might be absolutely fine. If you've got someone straight on from MDI, you might want to up it a little bit till the basal insulin's worn off. If the glucose variability is quite low, then you can lower the target down. Or if there's been a period of sort of frequent hypoglycemia, especially initially, the system's just being a little bit too aggressive to start off with, pop it up. And it's fine to kind of pop it up to sort of 8-9 millimoles per litre just for a few days, just while the system backs off, everything levels out. You get rid of the kind of undulations that you see when people are going from low to high to low to high. And you just let it all settle down, and then gradually nudge it down kind of 0.5 millimole a day or every other day till you kind of get back to where you want. When variability is more settled and lower, then what you can do is consider a lower target overnight. So one of the great things about the way you can personalize this, you can have different targets overnight during the day. So obviously overnight, when everything's easier to manage, you might want to consider maybe having it lower 4.5 potentially overnight, for example, and then higher during the day, where you're more likely to get some more kind of ups and downs, and you don't want to overshooting towards hypo range so easily. So as I said, consider just a starting target slightly higher potentially, especially with someone straight from MDI. Thanks. Next slide. And this, like I say, this just helps to avoid the lows, reduce the variability, and then you can more easily see what you need to do in terms of adjusting the carb ratios when you have a slightly raised personal glucose target. And this is just an example of someone who this was close to them starting on the system. And we actually, in this one, I think the personal glucose target, I want to say it's 8 or 9 millimoles. And that's made a huge difference in terms of, you can see they're not constantly running super high above that target, but they are, it's still kind of aiming for that level, but it just allows the ups and downs around that level just to be more settled while the system works out if it needs more or less at different times of day, or whether, so that you can see, for example, after that breakfast bolus has gone in there, this is dilute insulin, which is why it looks a lot of insulin. 16 to 10%, so that would be kind of a 1.6 and 0.67 bolus. Gives you the opportunity to see what you need to do with the carb ratios without risking the lows in the interim. I might have just taken over ones that you were supposed to be talking about, Julia. Apologies. Are you on the next slide, maybe?
Oh yeah, perfect. So yeah, I guess that leads nicely on to diluted insulin, which is still definitely a kind of something that I think is not that common, but I think as we are all using these closed loop systems and getting a bit more familiar with them, like Sarah was saying, of seeing that really there are situations where it seems to be beneficial. And this is just an example of someone where they had a really low total daily dose, and so the decision was made to dilute. And on the left-hand side, you can see there, well, their total daily dose is under 2 units a day, actually, so really tiny. And you can see that the closed loop system is really giving teeny tiny amounts of insulin, and sort of, you know, 0.1 units per hour, and at times really nothing for quite prolonged periods. And yet the glucose excursions at the top are huge, the swings up and down. So, you know, 0.1 units of basal from the closed loop causes sort of a huge crashing hypo, and there's just not any wriggle room for the system to modulate up and down, because the volume is so small and the insulin amounts are so small. And so it becomes really difficult to dose appropriately. And so we then, this participant then was put on diluted insulin, and you can see on the right hand side, so this is the diluted insulin, which is why the doses suddenly look so enormous. So you have to divide by 10, and then you end up back at similar doses, really. And you can see now, because there's a bigger volume of insulin going in, you can see that the system now is able to modulate up and down. So it can give what looks like quite a big volume of insulin when glucose is high, like they are overnight, and then it can back off. And you also don't have these really prolonged periods where there's no insulin being given, which can then lead to kind of peaks later on, when there's been a lot of time with no active insulin. So so I think, like Sarah was saying, it does add burden, because in some centers, you know, parents would need to dilute the insulin themselves and things. So it's not something to be done sort of off the cuff or lightly, but I think for certain situations, and particularly when the total daily dose is very low, it can be really beneficial, and it just can be really hard otherwise for the system to work properly. I don't know, I think, Fiona, you had said earlier that it's something you're sort of considering increasingly, and I wondered if you wanted to add anything here.
Yeah, I completely agree with the situation. I'm never confident when I see large gaps of insulin delivery on the baseline for any long periods of time. And I think it would be really lovely with more experience, and we are just gaining experience. I was, you know, Tim, Sarah was saying, oh, I'm coming on to learn, but we're all learning together. This is new, really, for all of us, and that's why it's so fantastic to share patient stories, because we are in this together. And the more we learn, I think there'll be a push to go for diluted insulin, and I think that will help us standardize how we do it, and our pharmacies then will put an expectation on them to help us with this. You know, we can't really have a situation where some parents have to do their own dilution, and down the road other parents get it done for them. I think we need to look at this in a lot more detail, and we'll be able to do that the more and more we push for this being a necessity for good use of pumps like this one.
Just to say really quickly that when Fiona's talking about segments where there's no insulin being given, on the left hand side where you see those tiny little blips, they're around 2 a.m. or that's really just a tiny pulse of insulin that's being given by the system to check set patency, tubing patency. So it's not really, it's like the tiniest amount. So it's not really any insulin that's going to have any effect. So really between, for example, sort of midnight and 6 a.m., apart from that bolus, there's no insulin being delivered by the closed loop system, even though you see those tiny blips. So that's just a quick aside in case you were wondering.
And another aside there, Julia, is actually this graph's a really nice example of trying to get those carb ratios right. And as Fiona said, you don't want big gaps after the, you know, at all, really. You want a nice kind of steady flow of insulin, like you would get, you know, if your pancreas is working, I guess. So you can see, like, if we're looking at that, when you look at this, the meal boluses there, this is for someone who's having bottled milk, are almost actually a little bit too aggressive, because you can see when the bolus goes in, the system then backs off to nothing and is almost like struggling to stop going. And I think there's been a couple of hypo treatments gone in there. So So, or extra carbs to kind of stop them going low. So like that's how you can kind of see when you give a bolus, trying to make sure that the system still delivers a little bit, doesn't need to back off to nothing. So potentially these carb ratios are slightly too aggressive in that slide. I'm going to go to the next slide. Thank you, Candace. Is that you or me? Shall I go? So just a quick mention. People often ask, what kind of settings do we need to update? Obviously, in children, the children are growing and should be being seen under best practice tariff in clinic every 3 months. So the things to remember to change on the pump, and this slide will be saved for reference in future. Just the body weight, which you'll find in the settings menu, goes up in whole kilos. If there's been a change, a whole kilo or more in body weight, it's useful to update the system there. It's also worth, obviously, if their total daily dose has gone up, then the safety default basal might need to go up. So you might need to just tweak the backup basal, the normal pump basal, in case it flicks into open loop and then needs to rely on that. And then just as the total daily dose goes up, you want to adjust the daily max and the bolus max in the doctor's mode menu. And there's just a reminder there, and we'll save that slide and that you can come back to another time if you need to, of how you get into that doctor's mode menu and just adjust those. And we suggest the basal max is half the total daily dose and the daily max is 3 times the total daily dose. So just a reminder on those.
Quick question there, Sarah. The minimum weight that you can enter in the system is 10 kilos. So what do you do for little ones that are under 10 kilos?
Put 10 kilos. And that's in that situation is when, because that's all you can do. And it's in that situation, you know, we've had a couple that technically we're using it off license, and under ones it's licensed for 1 and over. So in that situation, that's where you definitely might want to look at upping that personal glucose target initially, because as a starting point, the weight and total daily dose then might be slightly too aggressive if they haven't quite hit 10 kilos. Then obviously when they hit 10 kilos and further, then you can just adjust it, but it's fine, it works fine.
Great.
So managing meals, I think one of the things we all thought when we heard that, you know, closed loop was going to be a thing coming to us as people managing diabetes was that, oh, good, you know, it's going to reduce the burden in terms of not needing to really worry so much about carbohydrate counting and timing of meal boluses, because the system would kind of just be able to deal with it and mop it up. But actually, we found the converse is true. And if you really want to get kind of the 70% time in range, that kind of level, it's really, really crucial that you are kind of careful around managing meals. So bolus timing is really important. Generally, we say with any closed loop system, try and give the bolus 10 to 15 minutes before eating. Again, really difficult in this age group, you know, trying to kind of rationalize with a sort of 2-year-old why they have to wait 10 to 15 minutes before they can eat their dinner. So, you know, you just do your best with it. What's really crucial though is not getting into the problems that can be associated with late bolusing, and just a reminder that if you forget to bolus, the glucose will rise, obviously in response to the carbohydrate being absorbed, and the system will ramp up to try and get on top of that. If you then think, oh gosh, we've forgotten to bolus, and put the carbs in for that bolus and deliver it late, it's almost like giving double whammy, really. The system's ramped up to deliver a lot of insulin, and then you've gone in and given the actual bolus on top, and then the result is a hypo usually later on. The system can back off to nothing. You can see in this example, the system has backed off to nothing, but it can't suck the insulin back out. So then the only thing you can do is kind of take note of your directional arrows and alerts and alarms, and get in with some additional carbohydrate to help it skim. Otherwise, it's going to drop down below hypo most likely. So bolus timing is crucial. If you do forget a meal bolus, it's not the end of the world. Rather than putting the bolus in late, either maybe put boost on, which is a function where you can just press a button on the pump on the app and say, just be slightly more aggressive, please, for the next period of time. It's kind of around 30-35% more aggressive, or you might give a small correction to just help get on top of the glucose, but putting the full bolus in can usually cause a problem. Also, the accuracy of the carb counting and the quality and quantity of the carbs is really important. What we find, and particularly with breakfast, when people tend to be more insulin resistant, is that there can often be quite a spike in the post-meal glucose level after breakfast, and then the often what people then try and do is, okay, we need a bigger carb ratio, but sometimes it's just a case that the quality and sort of quantity of the carbs going in for breakfast just maybe need to be considered. There's no system in the world that will get on top of, you know, kind of a sort of high sugar breakfast cereal. You're always going to get a peak with that sort of thing, and if you just keep ramping up the carb ratio, then what can happen is you start to see it in this example, that you start to have the bolus goes in and there's a bit of a dip before the sharp rise, and actually all that would happen is if you up that carb ratio, you're going to get an even bigger dip, potentially a bit of a hypo, and then panic, treat the hypo, even a bigger rise. And so, yeah, just thinking about the quality and the quantity of the carbs, anyone that's starting, we really encourage them to just revisit the carb counting, get the scales back out on the side, hook them up with a dietitian if they haven't been seen for a little while, and just talk through that. Super important. And a lot of people ask, what do we do for those meals if they were on a pump before that they would have historically done a split bolus for? What we normally suggest with closed loop systems is that if you were doing a split, kind of maybe 70% upfront, 30% delivered as a wave, that you maybe just start by giving the 70% of the bolus upfront, and then seeing what the system does to deal with the rest. And you can also, if that's not enough, you might find, okay, it's peaked a little bit, but it wasn't too bad. Maybe we'll go for 80% upfront, or you might find that you need the 70% upfront. And then the next time you try and put boost on, either at the time of the bolus or preset it for sort of half an hour after the bolus for sort of another 2 or 3 hours after that bolus. But sort of make a note of what you do and see what worked or didn't work last time, and sort of try the next thing again until you find kind of what works for certain, those kind of, everyone kind of talks about those sort of slightly higher carb, high protein, high fat meals that tend to cause more of an issue, or pasta type meals, those sorts of things. So we talked about using boost in that situation. And the other thing that I think is really crucial in this age group is thinking about those children that tend to graze, or they've had a little bit of a pick and they want something else. And there's a function in the drop down menu that says add meal, which, as well as being a place where you can enter carbs that were given for hypo treatment, so that you clock them in the system, they're registered on the system. If you've got a child who is having a bit of a picky afternoon, or grazing a bit, rather than put kind of, 10 grams as a bolus, and then they have something else, another 10 grams, another 10 grams, another 10 grams, and then you usually get that kind of stacking effect, even though that it's been the right amount of carbohydrate gone in, there's often then a dip later on. On the add meal function, you could just put that carbohydrate in, but don't tick the hypo box, and then the system will be more aggressive for the carbohydrate, but not in the same way as if you'd put 10 grams, 10 grams, 10 grams, 10 grams, and bolused individually for them all. So that can be a really useful function in this age group as well. Next slide, thank you. I think Julia is going to talk through activity.
Yeah, so I'll try and whiz through these because I'm quite conscious that I think it's really important we have some time for questions at the end. But basically quite tricky to manage activity in this age group, as I'm sure all parents will agree, because it tends to occur unpredictably. So in older children or in adults, we often say, oh, if you're going to have PE or you're going to go to the gym, put ease off on before you do it, which is a sort of function that's the opposite of the boost that Sarah was talking about, where the system sort of backs off, and it'll also not give any insulin if the glucose is below a certain amount, or below 7. While it does reduce insulin delivery, as you know, it sort of can't suck it back out. And so if there's unplanned activity, it's not always quite as effective, although probably still worthwhile popping on. And particularly if you're doing something like, you're going out for a long walk in the afternoon, all together, a nice lockdown walk, something like that, then it can be really useful to pop ease off on for that time period, just to get the system to sort of back off a bit and reduce the risk of hypo. But it's definitely, I think, trickier to manage in the little ones. And then the other important thing, I suppose, to say just here that fits quite nicely is making sure you suspend the pump if it's disconnected for more than 15 minutes, for example, for like an activity or an exercise or something like that. And that's just because if the pump's not suspended, the closed loop system will think that it's still connected. And if glucose then rises and doesn't come down in response to the increased insulin, the system will learn and think that the person needs extra insulin at that time of day. And so really important to suspend, and that's currently you need to do that on the pump itself, suspend it. So it will then alarm and remind you that it's still suspended. So Yeah, I don't know, Fiona, if you've got any other tips and tricks on the FX system about activity or how to manage it.
No, and again, it's the variability. You know, you might do the same exercise at the same time of day or as near as toddlers do, and yet you get a different response. And you know, diabetes, I think it's fair to say, is hugely frustrating because we can't predict very easily what the response to exercise, food, weather, even emotions have on glucose. And I say to my family, as I said, the only things we can really control are insulin and the quantity, the food and the quantity and the timing of the insulin. But there are 200-300 different other things that affect glucose, and it's trying to do the art of the possible all of the time and still live your lives without too much frustration. So it's very individualized, and as you rightly say, writing things down, reminding yourself of what I worked last time and working from there rather than working out from first principle each time.
Thanks. The next slide, yeah. And then just a quick word on managing hypos on closed loop. So obviously in this age group, we usually base hypo treatment on weight. And so the gram amount will vary depending on the age of the child. But really in closed loop, you can often, more often you can get away with smaller amounts of what would normally be recommended as hypo treatment. And that's because the system, of course, is responsive. So usually it's already backed off before you even become hypo. And you can see that, for example, here at nighttime, that there's been no insulin given for about 3 hours by the time, or 2.5 hours by the time that the hypo occurs. And so there's really not going to be a lot of active insulin around. And if you then give a full hypo treatment, you get that really big rebound effect where they then go really high. And to avoid that, really, if you do get a hypo alert and you turn the phone on its side and you have a little look at what's been delivered insulin wise, and you can see that actually you know, closed loop hasn't been giving much insulin or any insulin for quite some time, then you can often get away with giving sort of half hypo treatment or even less than that. And it's just worth experimenting and seeing what sort of works, and particularly at nighttime. In the day, of course, you need to be a bit more watchful. If you've just given a big meal bolus and they have a hypo, then you're probably not going to get away with a tiny amount of hypo treatment because there's loads of active insulin around. So I think when there is a hypo in closed loop, it's really worthwhile turning the phone on its side and having a look at this trace and seeing what's happened, how much insulin has gone in, and kind of trying to make a decision based on that. And also, of course, looking at the arrows. And you know, have you got a steady arrow, or is it just maybe diagonal, or have you got a double down arrow and you think, well, actually we need to give the full hog here because otherwise we're really going to end up in a tricky position. But often you can sort of skim a bit more than you can with traditional pump therapy. Next slide. Oh yeah, I'll hand back to you, Sarah.
Yeah, so we were talking earlier about the burden of managing diabetes, you know, in any great age group, but particularly this age group. And I guess it's just to re-emphasize that the system has been designed to be as kind of, it's not plug and play completely, but it's meant to not need such a great effort. And you can see in this slide, this person, you know, the child hasn't got terrible control at all, but the family are working super hard with ease off and then boost and then ease off again and then leaving it for a bit, and loads of little micro boluses going in that you can see, and ease off and boost, and sort of kind of doing the opposite, I guess, from what the system has sort of been designed to do. And I think sometimes it's chasing these ultra tight or really high time in range, trying to kind of chase the sort of 80-90% time in range, that can lead to actually what ends up being potentially slightly worse time in range with more dips. Like Julia was saying earlier, the higher time in range is at the expense of increased levels of hypoglycaemia. And actually probably what you'd find is if they just left this alone, that probably control would steady out, maybe even raise the personal glucose target for a couple of days and just let everything steady out and the system actually do its job. It probably, it will be a whole lot less burden for the family, but also probably better control as well overall. So just, yeah, ease off and boost. The system doesn't learn when they're on. They're meant to be kind of a every now and again sort of just in case type thing, rather than a constant having to put one or the other of them on.
And Sarah, just at that point, if you don't mind me adding, what I also think here is that if you manage diabetes in this way as a young family, you miss your youngster growing up. They become a set of numbers and set of interventions. They aren't little people that are you're parenting and watching them develop. And we have to try and help families not see their youngster as a set of numbers. It's just not a good idea.
Yeah, absolutely. Okay. And the next slide, I think this is the last slide, and just, yeah, but this important problem that a lot of people seem to experience of this evening rise. And the difficulty with the evening rise, that tends to happen often when children have first gone to sleep, the glucose levels out of nowhere just fly up. And no one really quite knows why. And the difficulty with dealing with it is because it doesn't usually happen every night. So it's then very difficult to set things that might work as a regular, because you know, it often doesn't happen every night, and then you end up with a dip. So this is just a really nice example. You can see the chart on the left hand side is what was happening with one of our users who was constantly just finding the evening meal bolus had going kind of around 5 o'clock. They would like have some carbs, kind of a snack before bed. They'd go to bed with a really good glucose level, and then off it would go, and it would regularly go high, but then actually not every night, which made it difficult. And they tried all sorts of things. First of all, they were just leaving the system to deal with it, but actually it was sometimes going very high, above 20, and even sort of developing ketones at some points. And then they were sometimes getting into trouble because they was almost doing a triple whammy to try and get on top of the high. So they were letting, the system was obviously working to give lots of extra insulin in any case. They were putting, like you can see on this slide on the right, there's a 0.3 bolus gone in on top where the peak was high too. And then to cap it all off, they popped boost on for a couple of hours as well. So it's almost like a triple correction, which was then leading, this one doesn't go on from one day to the next. It kind of almost looks like it does there. There's a completely different night following on the slides on the right, and often leading to a dip the early hours of the following morning. And we tried a few different things. The trouble with boost is that when boost on, it's not learning. So like I said, boost meant to be an occasional thing. And actually what we found worked quite nicely was that looking at the direction arrows, they were kind of mindful of it of the evening. And if the arrows started to go up, like either straight up or up on the slant, that they would get in with a manual bolus. And we started with quite cautious 0.2. Then that helped a bit. Then we did 0.4, and then we got to the point where actually 0.6 at the point the arrows went up, if they did. And I'd say probably 5 nights out of 7 with this particular person it would happen. And then the nights that it didn't, for whatever reason, they didn't give the manual bolus. So it is a bit more work to have to put it in, but it definitely helped iron out that evening rise. I don't know whether, Fiona, have you got any other kind of experience or anything you can suggest around that?
Again, it's one of these variable features. I certainly do what you've suggested about tracking, because that's the thing about having continuous glucose monitoring. It's not just the number that you're looking at, it's actually using your arrow as well. That's really, really important. And with the combination of the direction plus the actual value, then you have to make a judgment call. And I think that's where people get very experienced about their own young person with diabetes and how they respond. And what works for one family may not work for another. So arrow and situation, what the young person's been doing at the time, or the effects of exercise, what might happen, and then the actual number itself. So three different parameters: arrow, glucose value, and what has been going on in their environment.
I think the other really nice thing on this slide that you can see is this is the same person, obviously, and you can see really the variability again, I think, just really nicely at the bottom there on the left. That's a day where they've needed closed loop to give quite a lot of insulin. And then the next day, similar sort of bolus amounts, and closed loop has given a lot less insulin. And I think it just shows that it's so hard if you're trying to do this all yourself. Because you'd have to basically have a totally different basal, you'd basically have to just adjust the basal rates or have a totally different basal profile from one day to the next, and in these young kids. And I think, yeah, it's just such hard work. It's basically impossible, I think, to keep on top of without going crazy. So I think, as Fiona was saying, so I think and I think tying in with what Sarah was saying about trying where you can to let the system kind of do its job, and not feeling like you have to intervene all the time, because actually it does sort of manage things quite well generally, because even if you know, if you had put on booster, if you had given a wee correction, maybe would the levels have come down, you know, half an hour quicker? Possibly, but you've also had to intervene and do something when you're really just, you know, it's so important to just try and live life and think about diabetes a bit less, for sure. So
yeah, this is a sort of pattern we sometimes see. You know, small children, sometimes they have a day in nursery and then the next day they don't go to nursery, or they have a play day at home because it's raining, and then they have a very active day because it's outside. And it's so difficult to say what to do on any one day and repeat it. It is literally deciding on a daily basis what you should do for special intervention. So that's just one of the other challenges, isn't it? One of the challenges we also missed out, and I don't like to point out miss outs, but it is important, is that a lot of young children have other carers. So they have nursery, they have grandparents, and the grandparents tend not to be quite as brave as parents are with managing glucose. So again, that's another added variable that we have to throw into the mix when we're trying to manage glucose on a day-on-day basis.
Really good point. Thank you. I think that's the end of the slides that we've got. Is that right?
Just ask a quick question. There was sort of a questions popped up in the chat that I noticed that's directly related to the evening rise. So I thought maybe it would be worth just handling it now before we sort of go back through all the other questions. The question was, when you give that bolus of the 0.6 correction, that's on top of the closed loop functioning, or do you come out of closed loop?
Yeah, no, you just can give it on top of the closed loop functioning, and it's a really good point. Actually, we sometimes see that people kind of put in phantom carbs, fake carbs, to kind of try and get the system to give an extra amount of an extra bolus, and there's absolutely no need to do that with the system. All you need to do is you go into the bolus calculator, and with it on 0 units on the first screen, you just press next, and it takes you to the next screen where the dose, which will be on 0, is in the middle of the screen. And if you touch that 0 dose, you can then roll it up to whatever you want to give. There's no need to be putting fake carbs in, and actually the system learns differently if it thinks you've had a meal bolus rather than actually a manual bolus, and it will learn from the manual bolus corrections that have gone in. So that would be the way to do it. You don't need to come out of closed loop to do that.
Excellent. So I'm going to go through some of the questions now. I think it would be great to just look at the questions we have and sort of get your feel on what's happening. There's lots of, Tim and Sarah, there's lots of resonation about, it was great to hear your story, and it was so nice to hear that you've had the same issues. There's lots of nodding, and we share the same thing, so it's lovely to have you on. There was a question about max dose of bolus and basal insulin on the system.
I'm trying to, the max doses on this pump are pretty high. I mean, they're way higher than you're ever going to need for a toddler or a tiny. I mean, we use the same system in non-type 1 diabetes in ward situations where people are having kind of 200-300 units of insulin a day. So the system has the ability to give much higher max boluses. I don't know whether that answers the question. Am I misunderstanding the question? I'm not sure.
Is there any maximum? I suppose that's...
There is, but I think it's like 75. I think the max bolus is something like 75 units or something ridiculous. I haven't got a pump in front of me actually, but it's super high.
Yeah, and then some of it also depends on just the doctor mode setting a little bit in terms of overall over the day. That's why it is important to update that, because if that's why we set them quite high, sort of, you know, like Candice was saying earlier, 3 times the total daily dose. Because if closed loop gives more than that in 24 hours, it will then kick you out of closed loop, because it's kind of maxed out on how much insulin it can give. But I mean, normally if you set it at 3 times your total daily dose, then obviously that's huge amounts of room. So you shouldn't really get into that situation. People only ever really get into that situation if that's not been updated for ages and they've grown lots and need lots more insulin. But yeah, that's the only time it would really sort of max out as such. And then obviously the algorithm will might not deliver as much as you think it sometimes ought to when someone's gone really high, and that might be because the day before they've had a hypo at the same time, for example. So actually the system's learned that it needs to be a little bit more careful at that time, and particularly in the really young ones, that can sometimes be tricky because of that high variability that Fiona was talking about. So sometimes if you see it and you think, well, why isn't it giving more, that will be part of the reason why.
Thank you. There's a question for Tim and Sarah. How are you finding managing the Dana pump and the set changes and on the Dana pump?
I mean, the set changes, well, actually there's different infusion sets. That changed, when did that in last summer?
We've tried different like cannulas that go onto the skin, but the situation, I think which may not be appropriate to all the different children, but because our son in particular, he's got a very small bottom, and so he doesn't have any like excess flesh. He can't have it on his stomach, he can't have it on his arm like maybe older children could, and so like the kind of puncture points for all the different things. So he's got the sensor and transmitter on one cheek, and he's got the moving cannula every few days on the other. And it just, sometimes it will cause a terrible reaction. You take it off and you're like, what's been going on underneath here? And sometimes it's fine. And so I don't know if that's like a reaction to the glue, or whether that's just how it would be, or if it's just at a bad angle. So
I think it's just to do with, it's just such a small area that we can actually use. So I think occasionally you're just going to get, like, you sometimes get little lumps under the skin. Or the other day he had some sort of
something.
Yeah, there was something under it that was stopping the insulin going. But generally, since we changed to the newer infusion sets, that's a lot better.
Yeah, much better.
Because it covers a smaller area, and the other one did make quite big sort of marks as well. So this one, there's not such a kind of, it's not an issue.
Did you use a pump before?
Yes.
Yeah, we did. Before the closed loop, I can't remember what the pump was called. Medtronic. Yeah. So that the infusion sets we use now are similar to the ones we used to have for the Medtronic.
And we had two different types. We tried two different types of cannulas with the Medtronic. So all in all, he's had like 4 or 5 different types of things that go in, and a couple of different sensors. So we've been so lucky to have all these options. But just the reality of it is that he's a lot of these things, maybe they are just not going to be working on the kind of dimensions of a small child, or a small child. Like now he's 4, but it's still very hard to try and find a site like in the tiny amount of area that we can kind of move around every few days.
Yeah, real estate is really crucial in these little ones, I think, and I think it's a really good point that you've made. Taking the things off really carefully, using like Lift Plus or Zoff or whatever, being really kind to the skin when you remove them, because I think sometimes there's an overlap, and then you take it off, and it's then when you get those sort of dry, red, itchy patches and soreness. So just being really careful how you take stuff off is really crucial for these tinies, isn't it?
Yeah.
Thank you. There was a question about using FX for an ultra rapid insulin to avoid the delay and having to, bolus and wait before meals. What's the research shown, or your experience?
Do you want to take that?
Yeah, I can take that. So we've been using FX for a little while, both in multiple daily injections and in the insulin pumps. My personal feeling, and I'm not being paid by the company, so don't worry, this is absolutely my personal feeling, is that FX doesn't really make much difference, I would say, using it in the pumps. And I still fundamentally believe that the way that we deliver insulin subcutaneously, and will do for the foreseeable future, needs to go before before food. You need to eat after your insulin is in, and that's very different from the physiological situation when you don't have diabetes, because your insulin's going into a different bloodstream effectively. So I don't believe that FIASP really means that you can get to the point of eating an insulin at the time of eating nor after. I still think both insulins require to be given in advance, and NovaRapid a bit further in advance, but they still both need to be given in advance of eating. That's my personal opinion and what we've looked at in our clinic. I know FIASP Nova would have you think otherwise, and even advise, I think, up to 20 minutes after, but that's a hard call, actually. I wouldn't recommend that clinically. But yes,
And the system is licensed for ultra rapid acting insulins as well as rapid acting. And I think, Julia, aren't you just going to start a study of a head-to-head FIASP aspart study in children? We've done it in adults,
yeah,
and we're going to do it in children now.
We are going to do it in children because it was interesting when you said what's the evidence, Candace, and the evidence doesn't really exist.
There isn't any.
So we're going to try and make some evidence.
Anecdotal. It's when your patients come back and say, "I've put the new insulin in the cupboard." That's the evidence to date. Is that right, Julia? We need to do a bit more research.
That is pretty much. Yeah, it's all, I think, really really interesting and I think useful kind of feedback from clinicians. But it's all very sort of just
personal opinions.
Yeah, exactly.
Yeah. And we've had a lot of people, like you say, try it and it's gone back in the cupboard, or it's been too stingy, actually, has been another feedback.
Yeah, so it's called the cupboard test. Is that right? We could devise a new test. Is it still in the cupboard after trial? But it works for some. It does work for some, but it doesn't work for everyone on a reliable basis. So we wouldn't convert the whole clinic onto FIASP. And say give insulin after eating or at the time of eating. That wouldn't be the message.
Thank you.
I think what we should always try and do is try these things, and I think quite often people feel with diabetes treatment, if you move to something, then you're kind of stuck with it. I think pumps have made us feel like that, because whatever you're on, you're stuck with for 4 years. But actually, if people want to try FIASP, fine. If it doesn't work, go back. You've not lost anything. And I think we're not very good at kind of doing that sometimes.
No, I agree with you entirely.
I think we've got time for just 2 more questions. The one question is probably not a question. Well, it is a question about Dexcom Follow, and I know that is coming, isn't it?
Yes, yeah. So we've been working with Dexcom to be able to provide Dexcom Follow. It's been a bit delayed by COVID, as with so many things, but we haven't got a firm date, but they said to us their first quarter finishes end of March, and they said that's the aim is for first quarter. So hopefully it will be available then for those that want it. But actually, we've had loads of feedback from families who have said actually not having it's been quite nice as well, because they realized they were such a slave to it. They've kind of got what they want from the Diasend app, and actually not kind of having the constant looking at Dexcom Follow all the time's actually been quite nice, and sort of once they've learned to trust the system. So yeah, but it will be available.
And what would you say, question about the key point or key differences between the CamAPS system, the Medtronic and the Tandem IQ closed loop systems?
Who wants to take that, Julia, or?
What are the key differences?
Or what are the key advantages? How is CamAPS different?
Yeah, so I suppose the most key advantage is that the system is licensed for children of this age. So it's licensed for anyone over 1, and currently the other systems are all licensed for either over 6 or age 6 or age 7. So they would then be used off license. So it is the only one that's currently licensed for young children. The other big advantage, in my opinion, I think, is that you don't have to get so many settings correct for the system to work. It's a bit more plug and play, and like Sarah said, it's not totally plug and play. You still have to do things and bolus, and there's still thinking that has to happen, but it doesn't matter. You don't have to get the basal settings right, you don't have to get the insulin sensitivity right, because the system calculates all that on its own, whereas some of the other systems you've got to get those settings right and then also keep updating them for the system to work optimally. So I think that is an advantage.
And maybe the use of Dexcom, because Medtronic, you need to do those finger pricks, don't you? The sensor. So I think those kind of things. Let me see if I've missed any questions, but I think in the space of time, I think we will call it there. Unless anybody, I can't see. If anybody does have any burning questions that we haven't answered, please feel free to get hold of us either via the website, camdiab.com, or the online platform. We're around. Please don't hesitate to. Oh, there's one quick question. Shall I answer that question quickly? Let's see. You've got a question, Atri. Do you want to answer it? Ask it. Hello? No, we don't want to answer it.
Well, what was Trey's question? Much more.
Hi, can you hear me?
Yeah.
Yes, we can.
Yeah, so it's Atri Ghatak. For those who, well, I'm at Alder Hay. So one of the problems we've had, I think, we think it's a fantastic system, but one of the problems we have had, maybe being in Liverpool, is we've had families not able to, they don't have the money for a phone. So that has actually been a problem, and we have accessed we've got a few now from charity funds. So I fully appreciate the advantage of having this additional, having a phone as the link between the two. But are there any plans to have an incorporated system? Because certainly sometimes we've had to, when they're at that cusp kind of age where they're 5 years old, closer to 6, and we've just made a move for T-Slim simply to get away from this telephone problem. So I was just wondering if there are any plans at all to have an incorporated system.
As I understand it, the vision for this is that it's always intended to be an app. I don't think that rules out that in the future, some company might want to have it on their pump potentially. I know that's not a road that is going to be gone down anytime soon. I think the idea of it has always been it's an app that hopefully the moment only links with one type of pump, although Dana RS, Dana I, and one type of CGM, but the idea that it will be kind of a pick and mix system, that it will link with a number of different pumps and a number of different CGMs as things evolve and there's more choice. But yeah, at the moment, I completely understand why it does introduce that there's an extra piece of kit, but yeah, it was always intended to be an app.
Thank you. Thanks, Sarah.
Excellent. Well, thank you very much. Thank you to Tim and Sarah for giving up your time. I know evenings aren't the easiest with young kids. And Fiona, I know you've probably had a very long day in the hospital, and I've got another few hours, and the same for you, Sarah and Julia. So thank you very much.
Yeah.
And thank you very much to everyone else listening and giving some input and asking some very insightful questions. Please feel free to register for the next ones that are coming along. We will hopefully see you soon. So thank you, everyone. Have a wonderful evening and stay safe.